Hi, everyone. My name is Leah Miceli. I am one of the third-year OBGYN residents at the Cleveland Clinic, and I'm happy to share my project with you regarding antimicrobial stewardship in patients with penicillin allergy undergoing hysterectomy. Allergies to antibiotic medications are common and represent a challenge to the treatment and prevention of infectious disease. Penicillin allergy is the most commonly reported drug allergy in the United States and is reported by 5 to 10% of the population. Patients' personal reports of penicillin allergy have low diagnostic accuracy, and only 10 to 20% of patients reporting allergy have positive penicillin skin testing. This discrepancy in reporting is often due to viral symptoms present at the time of penicillin was prescribed, often during a childhood illness or poor recollection of a reaction that occurred many years prior. Furthermore, for some patients, an allergy is an all-encompassing term, including intolerances, known side effects, and true allergic responses. Overreporting and propagation of unverified allergies can affect patient outcomes and lead to unnecessary cost and healthcare utilization. There are multiple types of drug allergies, and penicillin allergy can be conceptualized within the three categories listed here. They're listed in order of decreasing severity. Immediate or type 1 hypersensitivity reactions are mediated by IgE antibodies and the activation of mast cells. The timing of these reactions is within 1 hour of drug exposure, and reactions include anaphylaxis, urticarial rash, angioedema, laryngeal edema, and hypotension. Angioedema is pictured in the top left photograph and includes periorbital edema as well as swelling of the lips and tongue. Delayed reactions to penicillin are not mediated by IgE and are often mediated by T cells present within the skin. The timing is usually 6 hours to several days after medication introduction and are usually limited to skin rash without systemic symptoms or mucosal involvement. Many patient reports of penicillin allergy are not allergies at all and include intolerances such as GI upset, most commonly nausea, headache, mood disturbance, yeast infections, and many others. Hysterectomy is one of the most commonly performed surgical procedures in reproductive age women, second only to cesarean section. We perform over 2,000 hysterectomies yearly within our institution alone. Antibiotic prophylaxis prior to hysterectomy is recommended to prevent both superficial and deep surgical site infection. Recommendations have been standardized by both the CDC and our governing society ACOG and include cephalosporin antibiotics as first-line therapy prior to hysterectomy. There is concern for cross-reactivity between penicillin antibiotics and cephalosporin antibiotics, given their shared beta-lactam ring. The literature has shown that this cross-reactivity is lower than previously thought, which is 1% reactivity overall and 2.5% cross-reactivity between the two antibiotics in patients with a proven anaphylactic reaction to penicillin. Overall, cephalosporin antibiotics are well tolerated and have been shown to be very safe in patients with low-risk, non-IgE-mediated penicillin allergies. The ACOG recommendations for surgical site prophylaxis prior to hysterectomy are listed here in this chart. For non-IgE-mediated allergies, it is recommended that first-line therapy with ANSEF be utilized. Alternative therapy should be reserved only for patients with a history of IgE-mediated allergy. Prior to June of 2018, recommendations for alternative therapy included Cipro and Flagyl, and now they include a combination of either clindamycin or Flagyl plus gentamicin or aztreonam. The objective of this study was to evaluate the practices prior to hysterectomy within the Cleveland Clinic's Department of OBGYN. Our primary aim was to evaluate the appropriate use of antibiotic prophylaxis prior to hysterectomy in patients with reported penicillin allergy. Our secondary aims were to determine predictors of receiving appropriate prophylaxis and to evaluate the incidence of preoperative penicillin allergy testing. This was a retrospective cohort study of all patients with a self-reported penicillin allergy undergoing hysterectomy for benign indications from January 1st to December 31st of 2018. We included all women who underwent hysterectomy of any modality for benign indications with a documented penicillin allergy. Patients were identified using CPD codes for hysterectomy. Exclusion criteria included women with suspected malignancy or concomitant bowel surgery, and we also excluded patients who were already receiving antibiotics for another indication at the time of surgery. Patient demographics, clinical characteristics, medical comorbidities, operative details, and performance status as measured by the ASA classification score, were reported. Patients were placed into two categories based on the type of recorded allergy to penicillin. The first category is IgE-mediated immediate hypersensitivity reactions, including anaphylaxis or hives. The second category included non-IgE-mediated reactions, including rash, GI upset, dizziness, headache, or other and unspecified allergies. If patients had two reactions listed that were in different groups, the IgE-mediated reaction was used as a listed allergy. Appropriate antibiotic usage was determined based on the ACOG guidelines for penicillin allergic patients, with importance being focused on the use of Ancef in patients with non-IgE-mediated allergies. While Cipro and Flagyl are not currently considered to be appropriate preoperative treatment for patients with an IgE-mediated allergy, this was a recommendation prior to the updated guidelines in June of 2018. Any antibiotic treatments other than the regimens listed above were deemed inappropriate. A total of 230 patients met both inclusion and exclusion criteria for our study. Appropriate antibiotics were administered in 43% of our patients, while 57% received inappropriate antibiotics. This table serves to demonstrate that no differences in antibiotic administration were observed across demographic factors, including age, race, and preoperative renal function. MRSA status, BMI, and ASA class were also not significant. Across comorbidities, we found that patients with cardiac disease were more likely to get the appropriate preoperative antibiotic prophylaxis. No differences were observed in other comorbidities evaluated, such as hypertension, diabetes, renal disease, and immunosuppression. When evaluating allergy data, we found the total number of listed antibiotic allergies were impactful and that patients with 3 or more listed allergies to antibiotics were more likely to get appropriate preoperative prophylaxis. We next evaluated how antibiotics were administered by type of listed penicillin allergy. We found that patients with IgE-mediated allergies were significantly more likely to receive appropriate antibiotics, while patients with non-IgE-mediated allergies were significantly more likely to receive inappropriate antibiotics. An exploratory logistic regression was fit, predicting appropriate antibiotic use. Patients with 3 or more documented antibiotic allergies, any comorbidity, and IgE-mediated allergies at least doubled the odds of receiving appropriate antibiotics, while patients who were MRSA carriers had lower odds. Additionally, there were no differences in the practice patterns between generalists and subspecialists, the indication for surgery, and surgeries with mesh insertion. Although our study was not powered to formally evaluate incidence of postoperative infection, 4 surgical site infections were observed within our cohort, as well as 1 incidence of bacteremia. All of these patients received a non-cephalosporin antibiotic. Only 9 out of our 230 patients underwent preoperative evaluation of their listed penicillin allergy. In conclusion, we found that over half of patients with penicillin allergy received inappropriate preoperative antibiotics within the CCF system. Factors that impacted our practice included the presence of high-risk medical comorbidities and an increased number of antibiotic allergies. We also found that despite national recommendations, penicillin allergy evaluation prior to surgery is not a common part of our perioperative practice. Strength of this study include an analysis of the practice patterns for a variety of different providers, both within generalist and subspecialist divisions and across a large academic institution, as well as the use of the EMR for reliable data collection. Limitations of this study include weaknesses inherent to its retrospective design, and that it was performed at a single institution within one state. Lastly, the ACOG recommendations for appropriate alternative antibiotics were updated during the midway point of our study period. Although the choice of alternative antibiotic was changed, the indications for usage of non-cephalosporin antibiotics remain the same, and therefore the overall aims of our study were not impacted by this update. In summary, our study demonstrated the need for improvement in the perioperative practices in penicillin allergic patients undergoing hysterectomy. Opportunities for improvement include increased adherence to national guidelines and evaluation of penicillin allergies prior to surgery. Future goals would be to implement and evaluate clinical tools for improved adherence with guidelines for antibiotic administration, including educational tools for our caregivers and reminders of best practices within our EMR. It would also be beneficial to evaluate if standardized practices for penicillin testing would improve our rate of appropriate antibiotic administration. I would like to give a special thank you to my research mentors, Dr. Katie Props and Olivia Chang, for making this study possible, as well as Meng Yao for his statistical support and design support, as well as Selena Zhang for her help with data collection on this project. My references are listed as follows, and I would now be happy to take any questions.